Assalamu alaikum. How are you all? Hope you all are doing well. Today we are going to discuss clinical scenario number 2. So let's begin. A 42-year-old woman came with the complaints of exercise intolerance and dyspnea, which has been progressively increasing since last 1 year. So there could be various reasons of this dyspnea and exercise intolerance, maybe respiratory cause or cardiovascular cause. Then let's look at the vitals given. Pulse is 110 beats per minute and BP is 110 by 80. That's so far convenient because there's nothing abnormal in the vitals. But then he is giving you some information with respect to loud S1. Well, what could be the reason for loud S1? Loud S1 can simply be the result of tachycardia component as heart rate is 110 beats per minute. So not grossly elevated, but that could explain the loud S1. Then you see there is a wide fixed split of S2. Now, where do you find wide fixed split of S2? I think everyone knows, we have read it in case of AST. But this question does not seem to be of pediatric group, neither the question has this option. Now the bilateral lung fields has vesicular breathing, means respiratory causes ruled out. Chest x-ray is given, obviously it will give definitely key to solve the question. Let's look at the x-ray. You can see the aortic arch, and there is a problem just below the aortic arch in the left border of the heart. You can see a huge bulge which is present at the site of pulmonary artery. This is a very prominent pulmonary artery segment, which is a cause of concern. And remaining left heart border, that is left atrial appendage and left ventricle, which are okay and normal. You can also notice prominent pulmonary artery on the opposite side. Now let's just look at the options. Option A, interrupted aortic arch with undiagnosed VSD. Well, first of all, I want to highlight the fact that it is a neonatal presentation which can result in a shock-like state. So I am ruling out option A. Now look at option B, preductal coarctation of aorta. It's also seen in infants. It will be outlet obstruction to the left ventricle and it will cause left ventricular failure in infants. So option A and B are ruled out due to their age preponderance for pediatric group and is not matching with the age that is given in the scenario, because we are talking about a 42-year-old woman. Option C and D are left now and both are overlapping. Option C says bilateral hilar lymphadenopathy sarcoidosis. Now viewers, that's also not the case here, because there's no information given in scenario regarding sarcoidosis, such as we can't appreciate presence of fever, night sweats, weight loss, pain in joints and bones, skin rashes, etc. The opacities which are present in chest x-ray are not swollen mediastinal lymph nodes which are found in sarcoidosis. I am showing you the x-ray, the chest x-ray of sarcoidosis, and please notice the difference between both x-rays. Now look at the chest x-ray and please appreciate the findings which we see in case of sarcoidosis. Note the opacities in left and right hilum of the lungs. These are actually swollen bilateral hilar lymph nodes which are found in sarcoidosis along with joint pain and skin rash as the clinical feature. And you can also notice there is not bulge at the level of pulmonary artery below the aortic arch. So we can conclude by looking at the chest x-ray of sarcoidosis and chest x-ray of pulmonary arterial hypertension, and along with the hints given in the scenario, for example, no respiratory sign with fixed wide split of second heart sound, we have reached to the right answer of the scenario, that is option D, pulmonary artery hypertension. So today's discussion got little longer. I hope with my effort you are now able to crack the question regarding sarcoidosis or pulmonary artery hypertension. Thank you, and please don't forget to subscribe my YouTube channel. Allah Hafiz.